This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. January 2026, a whole new year. Ryan, how you doing?
We all stayed alive during 2025, and now
we did it.
We're going to do the same in 2026.
And fortunately, our audience just missed a very uninformed conversation about global warming. But why don't we move on to what we actually know some stuff about?
Yes, some stuff. The first article we'll talk about from the January 2026 issue is called Evaluating Acute Stroke Diagnosis Using Simulation Scenarios. Our lead author here is Ava Lieberman, and she's at the University of Chicago. This is actually quite a fun little study to read, at least, probably not in which to participate as a subject, primarily because, it's one of those studies that locks subjects in a live simulation and tests their diagnostic accuracy. There were 27 participants split between emergency medicine and neurology trainees who underwent this live fire exercise and attempted to diagnose or exclude a simulated stroke or stroke mimic. But the study isn't about their diagnostic accuracy precisely. It's about the effect of various factors provided in the history of each simulated case and their effect on the likelihood of making a correct stroke or non-stroke diagnosis. The 11 factors that could be affirmed or denied were a history of migraine, history of seizure, presence of atrial fibrillation, history of stroke, patient age, triage code stroke, presence of dementia, elevated blood pressure, current oral anticoagulant use, current antiplatelet use, elements of clinician distraction, and the presence of a witness to the symptom onset. That's a lot. And some of these are relevant to the 4 cases, one of which was a very typical stroke, one was a subtle stroke, one was a complex migraine, and one was an intracranial hemorrhage with decreased level of responsiveness. For what it's worth, the only case these trainees did well on was the typical stroke, of which they were perfect. They were correct in 65% of the subtle stroke and ICH cases, and correct in only 17% of the complex migraine. But getting past that momentarily, what the study was truly trying to determine was the factors relating to diagnostic accuracy. And they found that the most prominent associations with a correct diagnosis were the presence of a witness to symptom onset and the absence of distractions during patient evaluation. It's a small study of participants who are difficult to generalize to experienced professionals, but those top-line findings have face validity. Collateral information, lack of interruptions. In this era of potentially increased focus on diagnostic accuracy in the emergency department, it is quite reasonable to take some of these findings to heart. A physician engaged in a possible stroke evaluation should be considered off limits for interruptions. And a physician evaluating acute stroke will get their best diagnostic confidence when you have a witness to symptom onset. Now, I don't want to talk about that overdiagnosis of a stroke mimic, but I'll leave that third rail to you because otherwise we'll get through this podcast.
Yeah, I think the face validity point's great, but I also think it's like, sure, I would love to have an uninterrupted time to make my perfect diagnosis and then have all the collateral information, but none of those happen when I'm evaluating a stroke. They come in, nobody knows the onset time, nobody knows any history. The patient is sometimes altered, sometimes aphasic, sometimes lots of stuff. I'm getting EKGs from other patients shoved in my faces at all times. And so while these things are ideal, they are no way realistic to what's going to happen in the real life scenario.
Well, I mean, we had that AHRQ thing from a few years back that shows that we're killing hundreds of thousands of people every year with diagnostic problems in the emergency department. And, if your department wants to take that seriously, it has to cordon off physicians who are making these high risk potential diagnoses. Because at the same time, that AHRQ study, for what it's worth, as far as you could throw it, also seemed to show that clinicians struggle to make accurate diagnoses of acute stroke in the emergency department. So, again, this is a study that shows what makes perfect sense. Can you implement it? I don't know, but it's something worth thinking about if you want to take this kind of thing seriously.
Yeah, I promise. This isn't just stroke. If we have all the time to concentrate on a single patient and have all the collateral we need, we will do much better at diagnosing many things. Unfortunately, that's not typically the situation in our emergency.
Time to change our models of care.
Yeah. Okay. All right.
We can get better than 17% accuracy on a stroke mimic.
Yeah.
Which is moot. I mean, let's think about it. I mean, everybody's trained to just treat strokes.
Yeah.
Not to worry about a stroke mimic.
I think
it's the whole paradigm has changed, but still, it's just pretty funny that they didn't even come close.
The reason they're so good at diagnosing the traditional stroke here is because they worked everyone up for stroke, right? And so, whether you're the stroke mimic or the stroke, you will get worked up for stroke. And obviously, in this case, one of them looks good and the other one doesn't look so.
Yeah. And no neurology or emergency medicine trainee is going to be like taken out to the woodshed if they've worked up a stroke mimic as a stroke. But if they miss a stroke,
lots of emails ensue.
All right.
Our next article. So our next article is the accuracy of published screening tools for large vessel occlusions in patients with suspected acute ischemic stroke, a prospective cohort study. And the lead author is Dr. Mercer. So staying in the topic of stroke, this is the idea that identifying large vessel occlusions or something that we can send to endovascular therapy is important in this triage process. Knowing when to activate the machine and knowing when not to. And so these authors wanted to look at a number of published rules that attempt to identify large vessel occlusion and prospectively evaluate their performance. And so this is a prospective study. They enrolled consecutive patients with suspected acute ischemic stroke presenting to participating centers. And these were patients in whom the emergency physician suspected a large vessel occlusion and had activated a code stroke. So they were ultimately getting vascular imaging, which they used as their gold standard. So they studied quite a few decision tools for identifying LVO, NIH stroke scale thresholds, as well as RACE, LAMS, FAST-ED, and other similar instruments. The primary outcome was the presence of a large vessel occlusion defined by the CTA or other equivalent vascular image. So the authors enrolled 390 patients with suspected stroke. 111 or 28% of these had a large vessel occlusion. They essentially found that there was no tool that demonstrated both a high sensitivity or specificity at identifying LVOs. In fact, the accuracies were pretty low all around. And while some of them were fairly sensitive, they had awful specificity. And then the opposite was true as well. Some of them were fairly specific, but their sensitivity was unusable. So overall, most of them basically had diagnostic performance in a range where you couldn't really use clinically to determine when and when not to activate a stroke. I think it's a fairly well done study. Obviously, when you're going to look at this many screening tools in a population of 390, there's going to be some random effects, and the performance may be better or worse than in other studies. But it's not uncommon in an external validation set to perform far lower than the original data sets that these studies were done on, or that these tests were done on.
Yeah, I mean, it shows that there's a whole host of imperfect options available for you. And maybe someday there'll be something a little bit better, but I think people have been putting their brains together on this, and in the field and pre-imaging, there's just a limited amount of predictive power you can get. For what it's worth, we use LAMS out here. I don't know what you're using in your local paramedic cohort.
Yeah. I don't think we have one defined one, right? We have so many different EMS groups around here. But for the most part, I think it's clear that none of them are good enough to say you are or you're not having an LVO.
No. But I mean, you got to use something. So, I mean, it's about triaging and redistributing resources and trying to predict and trying to utilize the right centers for your transport. So when you have a lot of hospitals right next to each other, it's important. We're the only hospital in town, so it's more of an academic sort of calculation. All right, we are done with stroke. We will switch over to an article called Clinician Risk Tolerance and Rates of Admission from the Emergency Department for Medicare Patients. Lead author here is Peter Smolowitz, and they are at the University of Massachusetts Medical School. There's not a lot surprising here. In fact, I can basically sum this article up in one sentence. The most risk-averse clinicians admit Medicare patients more frequently than those who are less risk-averse. And, the precise magnitude of effect and the continuum of risk and admission is grossly unimportant, considering it will be blurred by the merging of this Medicare data source and the physician surveys. But there were 889 clinicians who saw 421,000 Medicare patients in this sample, and higher scores on the risk-taking scale, the stress from uncertainty scale, the fear of malpractice scale, and the need for closure scale. Higher rates of admission, and the effect was magnified for conditions with a higher average rate of admission. The more interesting part of this article is actually Diane Kuhn and David Schreiger's editorial, and we know there are all manner of clinician-level factors influencing the likelihood of any individual patient will be admitted. We know there is a gulf between the acceptable level of risk judged by an individual clinician and then the acceptable level of risk for an individual patient. Throw in the confounder of imprecise estimations of risk, and you get this recipe for chaos. And then, as Dr. Kuhn points out, can we even change clinician risk tolerance? And if we do, What is the magnitude of that effect on practice? And if we change that clinician's practice, does their clinical judgment and acumen remain intact? Does society tolerate interventions encouraging clinicians to take risks? Every culture is different, of course, and my New Zealand practice environment is vastly different than the United States, but the same variances exist. I agree with the author's call for increased shared decision making, along with policy changes to remove individual risk from clinicians, but I will note there remains substantial uncertainty surrounding the how and effectiveness of said changes.
Yeah, I mean, obviously there's the external factors, but since there's so much variance, there's obviously clinicians who tolerate far more risk and clinicians who tolerate less risk. And what actually determines that and how much of that is modifiable is unclear and not determined by this paper. It'd be interesting in like how you like provide comfort to these clinicians, right? Like do you have to admit these patients? Do you have to order all these tests, or can you somehow achieve the same level of comfort by other less invasive measures, like, you know, making sure the patient has phone follow-up and checkups and so forth? And is there other things you can do that will provide these clinicians who don't tolerate risk with the comfort to be able to kind of accept more what we would define as riskier situation?
It is so multifactorial. You saw there were like 4 different scales, and it's like you can go to Texas where there's basically next to no malpractice risk other than gross negligence, and you may or may not have a certain practice pattern because I think culturally in the United States it's still a zero miss tolerance. Or you go to a place like a Kaiser Permanente, even in a higher risk state, but because it's a culture together and everybody's doing the same thing based on certain guidelines, it may look like a riskier practice with a higher threshold for discharge than the people in Texas where the malpractice laws were like very favorable. So there's a whole bunch of different factors, and changing one of them doesn't necessarily have the desired impact. And then that doesn't even account we've only just been talking about the clinician factors because we're focused on clinicians. We haven't even talked about patient values and how to combine clinician risk and the patient's evaluation of their own risks. So it's an interesting and tricky subject, and well, this just barely scratches the surface.
Yeah, it's all about somehow providing the comfort to the clinician to change practice, right? Because right now the thing that gives them comfort is admitting the patient. It might not change outcomes, right? But it provides comfort to them. And so if you can provide that same comfort with a different action that is far less resource intensive, you might be able to make outcomes.
And it's very obvious that admitting some patients is actually higher risk than sending them home because of different, the adverse effects of being in a hospital on certain patient populations. So,
but that's risk for the patient, not risk for the clinician.
But that's
right?
different risk for a different person.
Our next article: emergency physician employment market share and concentration by ownership type. So, I mean, I think we've all experienced this over the last decade or so. Emergency physicians have experienced dramatic shifts in who employs them. I think we've all experienced when you're working for one company and then all of a sudden it's bought out and another company is now signing your paychecks. And this kind of affects how decisions are made, what leverage individual clinicians have within the healthcare system, who makes medical decisions, and what are the drivers of those decisions. And a lot of times this is all discussed anecdotally. But what these authors wanted to do was actually assess who has the market share of emergency department visits. So they did a cross-sectional analysis where they essentially looked at a number of data sources: the CMS Hospital General Information Dataset, the National Emergency Department Inventories, and something called the Ivy Clinical Ownership Data. And they wanted to look at ownership categories and define these in a couple of ways. Health system owned. So these are emergency departments who are essentially staffed by the healthcare system, which they kind of reside in. And then private equity. And these are basically owned by a private equity firm that controls this the staffing of these emergency departments, and they contract with hospitals and they staff emergency departments. And so this means the ultimate decision making is made by this financial investment firm and not by the clinicians themselves. And then the last one is physician partnership. So these are like either single or regional partnerships where the emergency medicine clinicians run their own emergency department, staff them, make all the clinical decisions, and make all the business decisions. And they looked at essentially the market share, defined as the percentage of national ED visits staffed by one of these three categories. And then they also looked at market concentration to see in specific areas how many of the emergency departments were staffed by these three categories. So what they found was about 33% of the ED visits were health system group staffed, 25% were private equity groups, and the remainder was physician-owned groups. Some interesting kind of other finding is the top three private equity groups accounted for 90% of the private equity staff visits, and 84% of the health system visits. Many of them were just regionally concentrated, right? Which makes sense, right? Because obviously when you exist in a health system, there's some geographic region typically they operate in, and many of the emergency departments in that region are staffed by that health system. So I think this is a nice quantitative analysis of showing what many of us kind of experience now working in the U.S. emergency departments, that more and more of our emergency departments are being staffed by kind of either large health systems or private equity groups, and the amount of like physician-owned groups is becoming smaller and smaller.
Yeah, I mean, it is what it is. It's a look at the reality that surrounds us every day. I thought the most interesting part of this article is actually figure 2, where it shows private equity market share by state, and there's actually a huge regional variation. If you live in the South and the Southeast, you are almost you're more likely than not going to be going to a emergency department that is staffed by private equity owned groups. I can't imagine that's good, but obviously this article does not delve into the actual clinician level and patient level effects on practice and outcomes,
which would be very interesting if it did, but unfortunately it did not.
Yes. And I'm sure that even if we try to do this research, the ground would shift under our feet before we even barely got to do it, because of the practice environment and the consolidation is changing year by year as the economy and the health systems go belly up and go down, and HHS funding changes and so on and so forth. All right, let's move on to a happier topic. How about a happier topic? Opportunistic screening for atrial fibrillation with continuous ECG monitoring in the emergency department. Our lead author here is Elsa Bismuth, and they are at Stanford University. So we've actually been on a rather protracted journey over the past 2 decades to take atrial fibrillation a bit more seriously. Without giving away exactly how old we are, let's just say that when I first started training and practicing, it was par for the course to occasionally diagnose atrial fibrillation in the emergency department, and these patients would sometimes get admitted for an evaluation of new onset AF. Sometimes these patients would go home with instructions to follow up with primary care for consideration of anticoagulation. Nowadays, in part because of the increased recognition of stroke risk and the new availability of oral options to initiate from the emergency department, it's definitely within our scope to make a diagnosis of AF, determine their risk for stroke and bleeding, and initiate an oral anticoagulant. This study asks the question, hey, obviously there's obvious AF, but what about people who incidentally show AF while connected to our cardiac monitoring? This is basically the equivalent of that new uptick in remote monitoring and smartwatch detection of paroxysmal atrial fibrillation out there. What these authors did at Stanford is they basically went backwards through 64,000 patients who were hooked up to monitoring in their emergency department, ran them through a machine learning algorithm for the detection of atrial fibrillation, and then broke this cohort down into 3 groups. No atrial fibrillation at all, atrial fibrillation, but already known, and atrial fibrillation not already known. They then looked at the natural history of these patients following discharge using California's Department of Public Health Vital Statistics database. So, the baseline incidence of stroke in those patients who did not exhibit atrial fibrillation and were not known to have AF, they had an adjusted cumulative incidence of stroke of about 0.5 per 100 person years. However, those with incidentally detected stroke or AF had similar stroke incidence, about 2.5 per 100 person years. And obviously, these patients were older and sicker than those without AF, but even after adjustment, the elevated risk of stroke remained substantial. The author's conclusion, hey, people with incidentally detected AF represent a population of potentially unmet need for oral anticoagulation and primary prevention of stroke. And for the most part, I'm inclined to agree, although translating these findings confidently into practice requires a bit more nuance. Paroxysmal or subclinical atrial fibrillation is a continuum of AF burden, and AF burden itself is tied to downstream stroke risk. And we're not all the way there as far as linking these subclinical episodes to improved outcomes with oral anticoagulation. This, along with some of those remote monitoring and smartwatch diagnoses, are ripe for confirmatory trials before operationalizing this practice. Not to mention the AF detection software used here needs further accuracy improvement as well. But I am, generally speaking, fully on board with that idea to take advantage of opportunities to make important incidental diagnoses in the ED, falling into the same sort of category of like at-risk pulmonary nodules and the like.
Yeah, I think I'm a lot less excited about this than you are. And I mean, I think you hit it. You said it all with this idea that this study shows maybe possibly there might be slight increased risk of stroke downstream in patients who they identified small runs of AFib while they're in the emergency department. But that's a long way to translating to we should be treating these patients. And my concern is, like everything we do in the emergency department, is we just keep adding stuff to the burden of our clinicians, right? And especially things that we are not looking out for, that it's really easy to miss, right? And you can imagine, it's like the pulmonary nodules. You're getting a CAT scan for whatever reason. They have a pulmonary nodule. I now have to make sure I document about the pulmonary nodule, that the patient was told that they have to follow up, and so on and so forth. And sometimes you just miss that because you were looking at something else and didn't even make that rate, and that can always come back to get you. And so I would want to make sure that you had a real benefit from doing this before you started asking to find AFib on a monitor in a patient that they weren't necessarily looking at it for, in a patient that maybe they shouldn't even be on the monitor at that point. But you got a long way to go. We have to, one, you prove that if you give these patients anticoagulation, the small amount of time that they are undiagnosed with AFib to when they get diagnosed makes a difference. Then you have to say that the underserved population that we have in the emergency department, starting the medicine in the emergency department that they still can't get as an outpatient, will make a difference, right? There's so many levels here, parts of the links in the chain that can be broken before we found a benefit. And I would just want to make sure that benefit's there before we burden our clinicians with more and more things.
Yeah, and actually, that's a little bit of what Claire Atzema went into in her editorial. It's just like, this is nice. Our health system's not ready for this. Like, we are not equipped in the emergency departments because of the way that we use the emergency departments and the responsibilities we put on emergency departments. Plus the whole like broken follow up and people connected to a difficulty for people to connect to ongoing sort of like health maintenance therapy and so on and so forth in the United States health system. And yeah, I mean, that's exactly right. As far as like, okay, we've detected this thing. Is it clinically important? And how clinically important is it? Is it actually the full stroke risk for this patient? Is it like an individually nuanced decision? I think that's the key, is like we've picked something up and we don't know in the emergency department how severe it is, because some of those patients have probably a very low burden of AF. They were detected in this study like for 30 seconds or a minute. And then you probably have some people whose burden of AF out in the real world is much higher and they might benefit from oral anticoagulation. That's exactly the sort of thing that's being investigated by a whole bunch of these like smartwatch and remote monitoring trials to see exactly what that continuum of AF burden versus oral anticoagulation, what kind of protection you need and what your risk is.
Yeah. Well, one of the best parts of what you said is, our health system is not ready for this. If and when our health system becomes ready for this, we won't need this because we'll have a functioning primary care system that actually can plug these patients into it. And they won't have to have this diagnosed in the emergency department. The only reason this is a possibility is because of the broken system, because we have so many patients that don't have primary care and are underserved and so on and so forth. And so this becomes, once again, some duct tape that we're trying to slap on to the broken system.
Yeah. And then what's funny is in our emergency department, we actually have an overt initiative to disconnect patients from cardiac monitoring because there's too many false alarms and chimes and bongs and distractions when people are hooked up to them. So it's just like, unless you really need to be on cardiac monitoring because you have an unstable arrhythmia or you're at high risk for something, we're not putting you on cardiac monitoring. So we're going to have a very small amount of these incidental diagnoses in patients, because the only patients we put on the monitoring are patients who are sick for another reason.
Yeah, exactly, as it should be. All right. Our next article, serious cardiac outcomes and physician estimate of risk in ED patients with pre-syncope versus syncope. The lead author is Edward Sue. So we've known for a while that the risk of syncope versus pre-syncope is fairly similar when you look at outcome data. But I think, like, anecdotally, the way we think about syncope and pre-syncope is somewhat different. And it's understandable. Patients that pass out versus patients who feel dizzy. It just seems that patients who lose consciousness are at a higher risk of badness than patients with pre-syncope. And so what these authors wanted to do was, what was the risk in this cohort, and then what was the risk assessed by the clinicians treating the patients, and did their risk assessment differ depending on whether you had full syncope or pre-syncope? And so they looked at a couple things. They looked at serious cardiac outcomes. We'll talk about how they defined that in a little bit. And they looked at how accurately the physician estimated the risk in these two groups. And this was a secondary analysis of a prospective observational cohort conducted in emergency departments. They enrolled adult patients greater than 40, presenting with either syncope, complete loss of consciousness, or near syncope, feeling like they were going to pass out. And the patients were followed for serious cardiac outcomes, was defined as life-threatening arrhythmias, myocardial infarction, structural heart disease requiring intervention, or death. And then they also assessed the physician's risk estimate. So after the patient was evaluated and treated, the clinician was asked to assess the risk of serious cardiac output. Oh my God. After evaluating the patient, treating the patient, the physicians were asked to estimate the patient's risk of serious cardiac outcome. And this risk was just clinical judgment alone. So there was no decision rules or any other calculators that were used by these clinicians. The authors essentially compared the rates of serious cardiac outcomes between the pre-syncope and the syncope group, and then the physician's risk estimate between observed and what they thought. So they looked at a little over 1,200 patients. 57% had syncope and 43% had pre-syncope. They look fairly similar on arrival. The pre-syncopal group may have been a little clinically less sick, but comorbidities and so forth was fairly similar. 30-day outcomes, 4.7% of the syncopal patients and 5.2% of the pre-syncopal patients experienced a serious cardiac outcome. Overall, 30-day mortality was very low at 0.4%. Most of the events were some arrhythmia of various flavors. And some of these we would all consider serious: bradycardia, complete heart block, so on, ventricular dysrhythmias. But other ones, like SVT, were not so serious. What they found was the rate of serious outcomes in the pre-syncopal group was very similar to the syncopal group. And when they looked at risk estimate, the physicians consistently estimated a lower risk for the pre-syncope group than the full syncope. The serious risk for cardiac the physicians estimated the serious risk for cardiac outcomes in the syncope group at 7.6% versus 5.3% in pre-syncope. This also seemed to show that they actually admitted people with syncope far more often. They admitted people with pre-syncope. So patients were admitted for pre-syncope at 38.2% and admitted for syncope at 49.5%. So all in all, I think this is a fairly well done study. I think it does show that we maybe underestimate the risk of pre-syncope compared to syncope. I think it shows we vastly overestimate the risk all around, as these physicians admitted quite a few patients, way more than what I think we commonly do in practice at this point. And the other thing is, like, the definition of serious cardiac outcome kind of spanned the gauntlet from death and very serious cardiac dysrhythmias to kind of mild SVT, that things that really aren't that dangerous in a clinical.
Yeah, I mean, I think the key here is just that syncope versus pre-syncope comparison as far as the risk estimates go. And it's like, okay, well, they had similar outcomes, yet the risks were judged to be slightly lower. I mean, we're talking like 5% versus 7%. I mean, it's there's enough patients in the cohort that it's significant in statistical means, but like that's really not clinically important. That difference between 5% and 7% serious risk of outcome, you can't really change clinical decisions based on that fine of a distinction between the two risk cohorts. The rest of it is just interesting, like descriptive statistics of like what happens to these people, which is interesting, and why are we admitting 40% of our syncope patients? This is 2026. Why are we? It's interesting. I think You don't know anything about what the clinicians were doing in these specifically to like, because there's individual risks and then you have these pooled cohorts. And I suspect that most of us as prudent clinicians are managing patients based on their individual risks, not like a pooled cohort of what a pre-syncope risk might be. And you can see some people had abnormal ECGs and some people were hypotensive and some people had valvular heart disease. And it's like, there's so much nuance and complexity to these patients. They're not just syncope and pre-syncope. It's hard to get anything out of the statistics and the descriptive statistics, but like that little bit of risk difference. Okay, yeah, sure. We do treat these people a little differently, but we probably treat them more appropriately than actual syncope.
Slightly more appropriately. They
Slightly
still admitted
more appropriately. Yes. We still admitted like 35% of the
Yeah.
pre-syncope patients. Jeez, or admitted or observed, kind of thing. Yeah. Oh well. Yeah, considering the risk estimates were that low, and then the actual outcomes, like people who required a cardiac intervention were like 1%. Yet we admitted like 40%. I mean, we're casting a very conservative net. Why is American healthcare so expensive? Blah blah blah. No, anyway.
It goes back to that risk tolerance study, right?
There we go. Take it back. All right. One more article from me. This one's going to be called Tranexamic Acid Timing and Mortality Impact After Trauma. Our lead author here is Adnan Ali, and they're at Australian National University in Canberra. So this article takes us back to all the controversy surrounding patch trauma. Patch trauma, if you recall, was one of those studies looking at routine TXA use in trauma, but responding essentially to CRASH 2 by putting TXA to work in the context of a modern trauma system, Australia, rather than the low resource settings of CRASH 2. The findings of patch trauma were a bit controversial in the sense that TXA reduced 28-day mortality after trauma, but by 6 months, there was no difference in overall functional outcome between the two cohorts. And as a result, no one changed anything about the routine use of TXA, for better or worse. And this is one of those exploratory analyses that looks at time to administration and whether a time-dependent effect exists for whatever benefit may be derived from TXA use. So these authors took the 600-odd patients from each arm, put their time of injury through the analysis, and found, at least with respect to 28-day mortality, TXA was only confidently beneficial when administered within 90 minutes, as compared to the 180 minutes allowed in the trial. Beyond 90 minutes, as they say, the treatment effect is uncertain. They also performed subgroup analyses with vascular occlusive events and sepsis, and each of those had 95% confidence intervals basically crossing unity, or at least basically no different between the less than 90 and greater than 90-minute dichotomous threshold. It's just an exploratory analysis, but it's more or less consistent with other similar time-dependent reanalyses of TXA in the setting of trauma. I'm not sure I necessarily buy much in the way of underlying harm for TXA in later windows, but there is some potential face validity for a beneficial anti-fibrinolytic effect from earlier administration. Generally speaking, I suspect most trauma systems around the world are already out there providing TXA pre-hospital to pursue exactly that beneficial effect. So this article doesn't really provide much basis to question what is already routine.
Yeah, I mean, this is the same kind of analysis I did on CRASH 2, which showed pretty similar results, that the earlier you give it, the more seemingly beneficial effect you have. I think the thing here is, they didn't look at the 6-month outcomes, which eventually showed that there was no real difference long-term between the administration of TXA or not. And so, yes, maybe it's slightly more beneficial early, but what does that mean downstream?
Yeah, but I mean, again, everybody's already doing it. Everybody's already doing it as early as possible, and there's not really any downside, and it's really inexpensive, assuming you've done everything else that you're supposed to do correctly in the setting of early treatment of trauma. Don't be rushing to TXA after you've already stabilized. Put the pelvic binder on if that's important, or gotten good IV access or whatever it is. So there's other things that are beneficial, and this should distract you from them. But I don't think it's moving the needle at all on anybody's practice in TXA, other than moving it forward, which I think people have already done.
Our last article of the month: cool running water as a first aid treatment for burn injury.
There's a movie called that, Cool Running.
Cool Runnings. The lead author is Mally Hobart. The major claim here is the application of cool running water for 20 minutes directly after a burn injury is recommended by multiple guidelines and has been shown to improve outcomes in mostly animal models. And so these authors basically want to determine the barriers and facilitators of implementing 20 minutes of cool running water in the pre-hospital or emergency department as like a first aid or initial treatment strategy. And what they did was essentially they took EMS clinicians and ED clinicians and completed an online questionnaire to to assess perceived barriers and facilitators. And then a smaller group of the same clinicians underwent semi-structured interviews to determine the same things. A total of 371, so 210 EMS clinicians and 161 ED clinicians participated in the questionnaire, and 14 EMS and 8 ED clinicians participated in the interviews. And they essentially found out quite a few things that they consolidated into 4 frameworks of implementation. And they looked at implementation barriers as lack of resources, challenges in adapting 20 minutes of cool running water to local clinical setting, absence of external policies incorporating burn first aid cooling. So, for example, patients with non-severe burns facing long wait times due to the high patient volumes in the emergency department. These wait times might often exceed the 3-hour window of treatment. And so how do you, triage these patients so they can get their running water earlier in their care? And then on the other side, unstable patients taken to ED, how do you give them 20 minutes of cool running water, take them to a shower somewhere else where you can get this done? It's going to require monitoring, physicians, nurses, technicians all be there while you're doing this process, which, has the potential of disrupting the rest of the emergency department workflow. They included facilitators, including high clinician motivation. There's strong professional networks, supportive clinical culture. You can build this into your EMS protocol, so on and so forth. Generally, it looks like the participants seem fairly positive and optimistic. Implementing such a policy would be feasible in the right patients. There was obviously concern for sick patients, for patients who needed immediate care. Delaying transport for 20 minutes of cool running water might lead to harm, so on and so forth. I think this was interesting. The question of external validity still stands. This is essentially one group in one system. And so how this applies outside of that system, it's a little unclear. And of course, the bigger thing is I don't think the data is so strong that 20 minutes of cool running water necessarily should be supported by practice.
Yeah, I mean, it's interesting. Like if you look at figure 1 in here, there's a lot of different variety of opinions about how feasible this would be, and it's like, how much effort would it be? And some people are like, no, it's really easy, and like some people are like, no, it's going to be totally impossible. It's like, it'll be easy for my team to adopt 20 minutes of cool running water into clinical practice, and some are like, yeah, I agree, and other people are like, oh hell no. It's like, well, wow, you guys got either a diverse group of people there, or some people are just really opposed to any change in their current practice of scoop and run, basically. I can tell you here, our EMS people will stay with the burns and run them under cool water for 20 minutes before transporting, because like that's the best time to do it and the best place to do it. Like the emergency department's not a great place to put somebody in a corner under a faucet, relatively speaking. It's easier to do in their own home usually. But this is weird a little bit that there's so much opposition to it, but I think that's just the other constraints upon people in the pre-hospital setting.
Yeah, I mean, I think ironically, the less the patient needs it, the easier it is to do, right? Like if you have a burn on your limb, the patient's not otherwise sick, having them run it under the tap for 20 minutes at home is totally feasible and doable. If you have burn on 45% of your body, you're pretty sick, you need resuscitation, you might need, airway securement, then all of a sudden this becomes a much harder thing to do. And so, differentiating those patients when and how to do it, I think is an important caveat to any of these protocols.
Yeah, I mean, they looked at that a little bit on the survey about like what things were appropriate exclusions to, 20 minutes of cool running water. Gave you a little bit of insight there, but I don't think there should be much of an opposition to this really, without using some common sense and transporting people early if it's prudent to do so.
Yeah, I think it becomes harder once you get them to the ED.
Yeah, I mean, and then they're like wrapped up at ambulance triage, and they're like, okay, put them in the waiting room. They're like stable. They don't need a bed immediately.
Locating a sink that works, that has cool water, that doesn't turn off with a motion sensor, right? Like these all become problematic.
All right.
I think that wraps us up.
Another great issue that you can all access online.
Yeah. As always, any comments, questions, or concerns, we can be reached at annalsaudio@asap.org. Otherwise, and until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.